Good afternoon, everyone. Thank you for persevering. And Tammy, thank you for the nice introduction. She was my mentor at the National Institute on Aging, and I thank her every day for that. So today I have the great pleasure of following some wonderful presenters, and I hope to give you some food for thought. And my disclaimers are that I wouldn't be here without my funding resources and the teams I work with. It's a very multidisciplinary team, and of course all my sponsorships are governmental places. So we talked a little bit about the unique characteristics of older adults that we need to consider for technology. Higher rates of comorbidities, cognitive declines in memory, higher rates of physical disability. What else? Medication interactions, transportation limitations. That's actually our biggest cost in our research studies. Social isolation and depression. And something that you also get with pediatrics and children is caregivers. But this is a little different, right? Because usually a parent is overseeing a child. But in this caregiver situation, older adults still want to be independent. But they also need extra care. So sometimes that can actually be a little bit of a conflict. Can I actually use this? Yes. Okay, so Jacqueline alluded to this issue of these monitors and the data out from accelerometers not being on a map very good with energy cost of movement. And we've actually demonstrated very similar. So if we look at, we take individuals who are over the age of 70, and we group them. We group them by having mobility impairments or not having mobility impairments. And it's not shown here, but these are the people without mobility impairments. And these are relatively normal walkers. These folks are slower walkers, right? They have mobility impairments. Now, when you ask them to walk a certain distance, their metabolic cost of activity is actually very similar of walking. But if you measure their accelerometer output, that's not the case whatsoever. It's about half as much in these people with mobility impairments compared to those people without. Yet none of our, our cut points or our approaches really take that into account. Now, getting raw data and getting that information, I think, will help with things, and that's kind of what we're working on. Another thing we have to consider is activity as a biomarker of aging, right? So most of the talks that we've really thought about, really for these 2 days, have really been looking at the surface level of activity. Right? What it is, you get so many counts per day, so many minutes per day, but there's so much data coming in. There's a lot more below the surface. And I think we can make use of it because a lot what we do is activity, is a biological function. It is related to cognition, mobility, self-rated health, and lifespan. In fact, if you look at just data from NHANES, right, you see this across the age span, this great decline in activity, right? We all know this. And we also know, and this is data published about 10 years ago, actually when I was with Tammy, on activity energy expenditure. Those people in the lowest tertile of activity energy expenditure had about a 3-fold higher risk of death compared to those in the highest third. And that's after accounting for all these factors that we are thinking that are related to mortality. So that's kind of the premise that we're kind of holding, is that activity is a biomarker of aging. Well, how about if we use these accelerometers as a potential biomarker? Well, this is a paper that was recently published, and we thought the same thing, and we used data from a pretty big study called the LIFE study, which we had about 1,600 people wear accelerometers over about 3 to 4 years. And what we tried to do, very similar to what Jacqueline was doing, is pull out features from this data. Now, at the time, this is count data. Now, I know we might argue what's better, count, frequency data. But we still were able to pull out 59 different features from this count data. And some of them relate to typical things, like your average bout length minute, your average activity count within a certain bout. but also the variability within counts and variability of counts within a specific bout. And not just one axis. Look at the other axes and look at them separately to see if those actually are connected to a person's mobility and outcomes related to mobility. So this is what we did. Those 59 features. Now, of course, I'm not a computer scientist, but I work with one. So we were able to say, okay, well, first of all, we don't know which computer science or machine learning language or technique is best. So let's apply a lot of them. And let's take these features and see if we can classify people with mobility impairments. Right? And this was a study that had a lot of people with mobility impairments. And you can see that we didn't do too bad. Right? It's not perfect. Our sensitivity is around 0.7. Our specificity is around 0.8, which is not too bad. And it really didn't matter which technique we used. They all gave about the same answer, which is actually encouraging. Now, how about if we can use it to actually predict something that happens in the future? Right, so this is an individual's mobility if we measure at some point at enrollment, and then we take that profile and we call them actigraphy signature. We take that signature and we say, okay, what is your risk of major mobility disability some point in the future? And the way we kind of quantify major mobility disability is the inability to walk a quarter mile. And that's not self-reported. That's actually coming to our clinic, our research place, and walking that quarter mile. And you'll be very surprised, over about 3 years, in this particular study, 32% were not able to do that at least one time. And many of them couldn't do it at least twice. So, and now you have to ask the question, well, how does it compare to other things? Can these signatures actually be important in comparison to other things that we think are important? So one is age, right? Gender. And this is intervention arm because this is part of a big intervention arm. And this explains a certain amount of the risk of major mobility disability, right? Anything we add to this, right, this is kind of our foundation. Anything we add to this, right, you add walking speed, that adds a little bit of prediction. You add comorbidities, more prediction. You add a person's BMI, weight, and height. But then you add features, right, these actigraphy features, and we just chose the top 5 because those seem to be just as good as all of them. You add even more explanation. In fact, the explanation there is greater than the explanation of walk speed or comorbidities. Right? So this is information that we can use, right, that we're not actually, exploiting right now. Now, another thing we're really interested in, and is really driving our kind of technology development, is intervening health events. And in older adults, there's things that happen in their daily lives, like a hospitalization, that knocks them down, right? We want to know how they recover from those, and if they do. Or does that set a new trajectory? And you can think of that either for activity or nutrition. So we call them intervening health events. And we can see that we know, I showed this profile before, that, physical activity generally declines in adulthood. And we know we can intervene with a structured physical activity program and maybe change the trajectory a little bit. But what is causing this trajectory? Is it aging alone? And what we think is it's not just aging, but it's also all these things that older adults get knocked down with. A fall that happens, you get fear of falling, you get fear of going out and doing things. So what we did was we had some data. Now this data, it doesn't exist very much because you have to monitor people for a pretty long period of time, and you have to monitor their hospitalization rates and all this other. So fortunately, I'm part of the LIFE study, which is, like I mentioned before, a pretty big study of 1,635 older adults, and they were pretty vulnerable. We do this physical performance test, and they have to be pretty low on this physical performance test to actually be to qualify. And but they had to have no major cognitive impairments. It's hard with the consenting procedure for that. But what's nice about this is they're randomized to either a physical activity group, and this is a kind of a moderate intensity center-based physical activity, or a health education group. Now, this is not a control. All right, it's a comparison. The health education was actually called the successful aging. They met once to twice per week at the beginning, and then once to twice per month during the middle and the end. It was very popular. And the idea was you kind of are able to remove the effects of contact, right? This interaction of the socialization that has that when you do a physical activity program. So nevertheless, we had accelerometry measured. Now this is from the hip, and this is from an old monitor. This is way back in 2009, way back then. All right, and 1 second epochs. So we have baseline measurements. We have at 6 months we have a measurement, 12 months, and 24 months. But this gives us enough time to actually look at these hospitalizations. Okay, if a person has a hospitalization here, how's it impact their month 6 compared to their baseline level? And they have a hospitalization here. How's it impact it? Right? This is the information that we want to know. So my doctoral student, who actually just defended his dissertation, actually one component of his project was to look at this intervening hospitalization effect. Well, hospitalizations can be short or they can be long, right? And that's usually an indication of severity. So we divided up by short durations, which was less than 3 days, and long durations, greater than or equal to 3 days in the hospital. About 30% of the individuals of those 2 years has one or more hospitalizations. So these are broken up by bout lengths. Now, this is kind of a complicated graph, but we have sedentary on this side and above the 0, and activity. And let's just look at the 1 minute bouts, because that's just the total activity. We can see that when a hospitalization happens, regardless of the intervention group that you're in, your activity is knocked down, right? It's worse if you're in a longer duration than if a shorter duration, but we're talking anywhere from 9 minutes to about 18 minutes, doubling the effect. That's per day. That's a lot of minutes per day. And it doesn't change. Like, people don't bounce back. There was no effect of time. And that was really important to find, because we expected that to actually happen, that people would bounce back, but they didn't. And now it's a little different depending on the length of the bout that you look at. Oh, first of all, let me just step up here. This is sedentary time. Sedentary time increased, right? So you have an increase in sedentary time about 5 to 15 minutes. And also a decrease in activity. Now, you start to see separation when you start to look at the bout across these different bouts, right? But the important thing is that these hospitalizations have an impact, and they have a pretty big impact. And the effect of so we had this this other group going along during the same time of doing this chronic physical activity intervention, and they get hospitalized, and we had this whole set of protocol to get them back, right? The whole idea is get them back. You got 30% of your sample going to the hospital. You have to have a way to get them back in the intervention. Well, so the intervention, it suppressed the effect, but it didn't remove it, right? So these individuals, the intervention is effective compared to the other group. But in reality, what's happening, compared to those people without a hospitalization whatsoever, these people in the structured physical activity do get impacted by their hospitalization. They get knocked down, and it starts this new trajectory because there's no time effect. They get knocked down again when they have another health event, and they get knocked down again. So this could be a potential explanation of what's going on, and this is, the way we're thinking about the data, and I hope to convey, maybe we can think about it as a group, and that this is a biomarker. This is what's happening, and this could be used as a good way to target individuals that are not bouncing back, to get them back on their normal decline, and so these health events are not even hospitalizations, but they're falls. So this is kind of changed the way we kind of think about the technology that we're trying to develop within the core. And You've seen a lot on the Actigraph and other devices, ActivePal and things like that, and we use them ourselves. But we thought, well, first of all, these things don't measure a whole lot of sensors, right? You saw Jacqueline's slide where the person's wearing a separate device for every sensor, right? And it works great for a research setting, right? Works fantastic. But now, all these things like we use the Samsung Gear. Now it's the S3. This is the S1. This is the S2. But it has a triaxial accelerometer, has a gyroscope, has a GPS, has a heart rate, has a UV exposure, has a barometer, and really critical here, it has a GSM data plan. Right. So if you have that data plan, all of a sudden, if you get somebody savvy enough in computer science to develop you an app, well, now all of a sudden you have real-time connection. And people, when I work with the students and stuff, why can't they just use Wi-Fi? Well, older adults don't all have Wi-Fi, right? So we have to have something in the background collecting data that can beam to the server and kind of give us information pseudo real time. And the price is right? I paid $200 and something, paid $200 and something there. I get the same thing. And we've tested the hardware on it, and the hardware is spot on compared to Actigraphs. All right, so we call it ROAMM, real-time online activity and mobility monitoring. And the idea behind this is that we collect information. It's being placed behind a firewall. This information is then, you can be reported in real time as kind of raw data, or you can kind of summarize it and get kind of your normal total activity levels. And you can get an idea of this community mobility and life space that Jacqueline was talking about, and because it has a GPS sensor. And you can get patient-reported outcomes, right? This is very similar to ecological momentary assessments, and another discipline is called PROs. And what's cool about this is that you can, if you have the right people who know how to do this stuff, you can develop a nice little interface. And if you're a researcher, I want this sensor, I want this sensor, I want this sensor right now. But I want to conserve battery life when it's out there, and I'm going to turn off this sensor and turn off that sensor and turn on that sensor. Right. So, but you can communicate with it because it's connected to that data plan. And when it's out in the field, you can monitor the battery life. Right, so it's being drained. Right, you can send an SMS text. Oh, please charge me. You can know if a person's not actively wearing it. Now it is a wristwatch, and it's pretty cool. Even the older adults think it's pretty cool to wear the watch. But you can look at if a person was wearing it or not, and you can view graphs and view details of the data coming in. Another thing that I really want to see us doing more, and we're kind of going into this as well. This is a very starting place for us, is capturing this activity data, again, relating it back to a person's patient-reported outcome. If they have pain, how does that go and affect their activity? And if those things are integrated, if they're being collected at the same time, then you can really think and understand how that symptom affects their life in their free living state. How do we measure pain now? We do a questionnaire. Right? How do we measure fatigue? We do a questionnaire. And it's recalling, within the last 2 weeks, what was your average pain? Where was your average pain in your knee? But this is getting at connecting it in free living conditions back to activity data. And what's cool about that you can't do on the research grade devices, again, if the right people, you can actually create the features on the phone. The phone has a processor, right? Not the phone, sorry, the watch, right? So you develop a script to actually create the features right on the watch. You save data, and you send the feature to the server so you can then display it. Now, I'm not here to say that this is not a challenge. It's a major challenge. We have a lot of micro challenges. And it was mentioned before, battery life is a pain. Every time we turn on a sensor, our battery life goes down. If we do all sensors, we're basically losing at 1 hertz. We'll lose about 30% of our battery life within 1 hour. Right? You can't measure for very long if you do that. Right? So that's the challenge we're up against. And then another issue is data size. Right? So our data plans can become very big. Right? So this is where we've actually decided to create the features on the watch. That way we send less data. But every time you add a sensor, you add more data, and you add more data per hour. And if a person is wearing this for a prolonged period of time, and that's our goal, right? We want people to be wearing this long time to catch those intervening effects, intervening health events. And the only way to do that is have them wear it for a pretty long period of time, because these things are random. All right, so the idea is that this is the foundation, right? If you have an app developer, then you can create this idea, right? EMA, you get an activity from the sensors, you have life space data, and we're working with the Cognitive Aging and Memory program to develop, a little memory test on the device. And of course, because these are coming in real time from the cell phone signal and you're displaying it, well, then you can think of some interesting interventions, right? And, sending, like you said, prompting for life space activity and for pain relief. All right, dietary intake. All right, so I'm not a nutritionist, but I have done a lot of stuff on doubly diluted water, energy expenditure, and we know that older adults have lower lower levels of resting metabolic rate, activity, energy expenditure, and they tend to lose weight, right? I know obesity is highly prevalent in older adults, but even those people who are obese in older adults, they tend to lose weight after the age of 70 years of age. And a lot of what we're kind of concerned with is preserving nutrition, right? And making sure individuals are getting the right protein intake. And another thing we have to consider is that it's been mentioned, how technology is being used or adopted by this population of 65 and older. And some people say, well, it'll happen. Well, in 2015, we're still pretty low, right? This is smartphones, so about 30% of 65-year-olds have a smartphone right now. Now, this might increase, but if you want to do something right now, you're going to miss a big part of the sample, right? And there's another issue, and this is even in obese older adults, is something called anorexia of aging, right? Physiologically, you lose hunger signals. You have loss in satiation, you feel satiated quicker. Higher satiation. And that results in a lower energy intake. So, when I was kind of watching the talks from yesterday, it kind of got me thinking that, physical activity ascertainment has become successful. We've moved on from self-report, not completely, but we've moved on a little bit from self-report because it's passive, right? It's a passive thing. You put this on somebody, they go along their day, they don't know what it's doing, they're just collecting data, and they don't have to do anything with it, right? Well, that's not the case for nutrition, right? All the presentations I saw yesterday, you had to input, you had to have the user input. Somebody had to put something in it, right? You had to take a picture or type something in. But maybe we need to think about, can we sacrifice a little bit if our target population, if our target is like a caregiver who is interested in, is there food available, right, for my mom, right? What's in the pantry, what's in the refrigerator? Is it fresh? Is there enough protein available in the refrigerator? And then, we have these systems that are supposedly these remote caregiver systems. And it's kind of an atrocity because they're basically made up as medicalize devices, and that's all they do is make a phone call, right, to the emergency room to say, come and help me. But there's nothing about nutrition, there's nothing about activity that these things can provide. And I think we could really improve upon that. And again, depends on this idea of remote caregiving is becoming really popular, especially within my generation, who may not be very close to their relatives, right? But we want to try to care for them. We want to try to do as much as we can for them. So how about, this idea of this Samsung fridge, this smart fridge, and it taking pictures for you and sending it to your phone. And that information can be, right, it's kind of similar to the photographs that people were taking of their plates. So can we kind of build upon the Internet of Things and the Internet of Appliances to kind of build this idea of collecting passive information to make it more usable, especially within a population that has memory issues and has cognitive issues? And can it be connected to individuals, remote caregivers, researchers, and practitioners? And could it also be expanded to other places where there's food in the pantry? Probably. Wouldn't be too hard to do that. And then, so soon we'll all be paying with our phones, right? And these receipts actually hold some information, right? This person bought green bell peppers, and how much they actually bought. We know the nutritional content of that, right? That's pretty well measured. We'll know the grocery store which they bought it from. Can we actually use that information on a passive way to know that that person bought it and probably took it into their home, because we have a picture of it on their refrigerator? Now the question is, can we know if they actually ate it? Also, digital receipts from restaurants, right? Older adults, like mentioned in the first talk, older adults tend to like to go out. Well, same thing. It's a digital receipt. We know the amount of food that they purchased, and we can kind of do a lookup table and at the restaurant. Although not all restaurants provide this information, many do. So maybe connecting these things, like you get your receipt. You know that piece of food eventually made it into the refrigerator, and I'm a caregiver, so I'm going to look it up. My mom's got food. All right, she's good. Next is the food available? Is it fresh? Is there a protein? Is there vegetables? Right. If not, okay, well, I know to call a grocery delivery service because my mom can't has no transportation anymore. So, and then we of course always kiss our mom, and we say she's happy and she has groceries now. So this type of intervention could work very well. Now, do we get very precise energy intake and all this type of stuff? No, but for interventions in the elderly, which are interested in making sure food is available and the type of foods on a general basis, it might. Or maybe you couple that, if you really want the nitty-gritty details, you couple that with food recognition and digital photography. The trouble that I can't figure out, that maybe we can discuss later, is how do you get the garbage out? That's one thing that they can't quite figure out, so to get the actual intake. All right. Another thing I was kind of intrigued with is this idea of maybe communicating with a hub, health hub, and maybe Google Home or maybe Amazon Echo could actually serve in this role. So refrigerator communicates to the Google Home what's in there, and Google Home always says, "Oh, how are you doing today?" And you say, "Well, looks like you need some healthy protein in your." And should I buy some groceries for you? Because our grocery delivery service will become pretty ubiquitous one day. And I'm going to also send a text message to your caregiver just to say I'm ordering groceries for you. So this technology is not there yet, but this is food for thought. Another thing that I think I wish we could be better at is getting this information to practitioners. That actually are caring for our elders. So again, back to our refrigerator, getting information back to the electronic medical record, and does a practitioner need to know that every food in the refrigerator? No. So you need some sort of algorithm here to say, okay, well, they only really need to know the basics, that they have food in their refrigerator and maybe enough protein. And if they don't, then that's connected to Meals on Wheels. And that information, Meals on Wheels delivers food, and you have food back in your refrigerator. So I'll stop there, but I did want to say my key takeaways here are really, exploiting this, rich data source as a biomarker of aging to maybe increase our ability to identify those individuals at risk. And I think we could really make a big difference there. And then the other component for nutrition is thinking about connecting passive devices to get at not exactly the whole picture, but a big component of the picture, at least to do intervention studies in elders and help them improve the quality of their life. Thank you. And by the way, this is a gator that I took a picture of across my building, and we teach our alligators to walk around the cross path.